everybody. Thank you very much once again for inviting me. 'Cause I always think that journalists are really the most important aspect, the missing aspect of TB, because you saw the movie, you've heard lots of other talks yesterday from very good, important speakers, and you say, my God, this is a gigantic, huge problem. How come no one knows about it? Which they don't. You didn't know about it before you came. And that's because journalists aren't telling the story that needs to be told. And your editors aren't interested in it, so you've got to push it. So maybe after these few days and this week, and you'll see what a big problem this is, and then you'll push and you'll win a Pulitzer Prize. So with TB, really it's always been a huge problem. During the 17th and 18th centuries, 20% of adult lives were due to TB. Between 1850 and 1950, 1 billion would be people who died of tuberculosis. This decade, we're going to have 300 million new infections, 90 million new cases, and 30 million deaths. And because populations are growing, more people died from TB last year than any year in history. This is the slide from WHO. Could be updated like last week. The new Global Tuberculosis Control report came out. I didn't update it because I was traveling, but you'll have that report and you can just, the numbers are pretty close. All forms of TB, 8.7 million people. These are confidence intervals because obviously these are not precise numbers, of which almost 1.5 million people died, and that includes deaths due to TB and HIV. And then for HIV-associated TB, we have over 1 million. 13% of TB was HIV-associated, and almost 500,000 people died of that. Multiple drug-resistant tuberculosis, which you've heard about in the movie you just saw was more than 500,000 people, cases in the world, and no one knows how many deaths due to MDR-TB, but probably more than 150,000. And then childhood TB, which is being more and more recognized as an entity just because it's even more ignored than regular TB. It's almost 500,000 childhood cases, and more than 50,000, 64,000 children died, and that excludes deaths due to TB and HIV. Incidence rates, you can see on this slide, the darker the blue is, the higher the incidence rates are. So the highest rates are in Africa, and that's linked to high rates of TB infection. But you can see India, China, former Soviet Union also have these high rates. And I think they're giving out the slides, aren't they? Aren't you giving these? So they don't have to take pictures of them because you'll have all the slides in your folders. So unless you want to take.
We'll have them on our website.
Yeah. Okay. So here's where all the cases are. The biggest bunch is Southeast Asia, but Africa follows with 26%. But the cases are distributed all around the world. Now, the background of global TB control is really very simple. In 1991, and that's relatively recently, right? The World Health Assembly finally recognized the growing importance of TB as a public health problem. And they developed a new framework for TB control, and that's the global strategy known as DOTS. And one thing you'll hear about this whole week in this course is dots, 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 lots of dots. And DOTS is a very confusing name, and if they had it to do over again, no one would call it DOTS. But they called it DOTS, and now it's a brand name, and they can't get rid of it. And it means directly observed treatment short course. So people say directly observed treatment, DOT, means you watch people take the medicine. But that's not DOTS. DOTS is a menu of other things. And the menu of other things are political commitment, so you can have as many people being watched, but unless the government and the policymakers and the funders think it's important, it's not going to work. So that's a part of the original DOT strategy, although There's no acronym that includes political commitment. Also, case detection, using smear microscopy among people seeking care for prolonged cough. Now, that's not covered by watching people take the medicine, but that's a part of the DOT strategy. And then standardized short course therapy under proper case management conditions, including directly observed therapy. Okay, so there's the DOT, but it's only one of 5 elements. The other 4 elements are not mentioned in the acronym DOTS, but the S covers for all those other elements. Regular drug supply. You know, you have a place like in Nepal where the clinic is a 12-hour trek away, and the patient is well motivated and treks to the clinic in 12 hours and gets there. No, we didn't get our drug delivery. That patient's not going to come back. So regular drug supply is a part of the DOTS strategy. And standardized reporting and recording system that allows assessment of the individual patients as well as individual program performance. Get your definitions straight. How many cases, how many deaths, how many new infections, all those kind of things. But they recognized with the original DOT strategy that it wasn't covering the new important issues that were screwing up TB control in that period of time. So they changed the DOT strategy. They changed the name to the Stop TB strategy. And the Stop TB strategy was the DOT strategy plus a whole bunch of other elements. So pursue high quality DOTS expansion and enhancement. That's the key. Plus addressing TB HIV, addressing multiple drug-resistant tuberculosis and other challenges, contribute to health system strengthening, because if you have good health systems, a lot of this stuff would go away. Engage all care providers. We recognize that it's not only the government, the ministry that's given TB care, but in a lot of countries, half the care is given by private practitioners. Empower people with TB in communities. The people with TB are a very powerful group. Let them tell us what they want and let them advocate for what they need, and enable and promote research. And this recognizes that you have worst case scenarios going on. Co-infection between TB and HIV, which we'll talk about. But TB promotes HIV just as HIV promotes TB. Multi-drug resistant tuberculosis, you've heard about that, you'll hear much more about that. Resistant to the 2 most important powerful anti-TB drugs, isoniazid and rifampin. Extensively drug-resistant tuberculosis, XDR. That's MDR plus resistance to the best drugs that are used to treat MDR. So they get in a worse quandary. And then finally, in some reports of totally drug-resistant tuberculosis, resistant to everything, which of course you don't have to be a brain surgeon to recognize what that means. So TB HIV, to talk about first, 1/3 of the 33 million people living with HIV/AIDS are co-infected with TB, more than 10 million people. And without treatment, 90% are going to die because HIV and TB form a lethal combination. Each one speeds the other process. Now, we always knew that HIV speeded TB. That was known. But it's less well known that TB promotes HIV. A patient that has HIV, his HIV gets worse because of the TB, and that's not as well known. And TB is the leading cause of death among HIV-positive people, 50% of people worldwide, which means if you have TB plus HIV, you're far worse off. This is what the graphic looks like. The world has, you all have heard the figure, 2 billion people, 1/3 of the world's population, is infected with the TB bug. Most of them are not sick, they just carry the bug and their body defenses contain that infection. So they're the green population here. And then you have a separate population in brown, the HIV-infected population, much less. Now you can see that the green population has a 10% per lifetime risk of getting active transmissible TB, which makes them sick and might kill them. And the brown population isn't infected with TB. So they have a tiny, 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 tiny risk of ever getting active, infectious, transmissible, I didn't do that, TB, which is going to kill them. But there's an overlap in pink where the people are infected with the TB bacillus and the HIV virus. And those people, since HIV robs their immune system, which protects the green population from getting active TB, HIV robs it from them, and you can see they have a 10% per year chance of getting active transmissible TB, which may kill them. So that's why HIV plus TB is much worse than either one alone. And you look at the HIV prevalence in new cases, again, the darker the blue, the more there are. Southern Africa, Brazil, rest of Africa, former Soviet Union, a few places in Southeast Asia, and some in North America. But there's still a huge HIV prevalence in new cases. And you look down in Southern Africa, new cases of TB in 2010, 50% were HIV positive. So that's a double whammy. That's a huge number. That's a tragedy. Now, World Health Organization has a policy package addressing, integrating HIV and TB. Because for a long time, the HIV community, doctors I'm talking about, only dealt with HIV, didn't even acknowledge TB exists. The TB community, much smaller, much less funded, much less powerful, said, hey, TB is important too, but no one would listen to them. And the poor patient would go to the HIV clinic, mother, HIV positive mother, a few kids, possibly some of them HIV positive, goes to the HIV clinic, waits all morning with 100 other patients for treatment or antiretrovirals or whatever they're getting. And then in the afternoon they go across town, 3 buses, transfers to the TB clinic, which is of course somewhere else, waits in the clinic all afternoon for the TB care. They wouldn't integrate them. And these diseases need to be treated together. So the World Health Organization has a 12-point policy package, a mechanism for integrating HIV and TB services, activities to reduce the TB burden in people living with HIV/AIDS, and activities to reduce HIV burden in TB patients. And the union itself has a separate but just as good programmatic guide for implementing collaborative TB/HIV activities. So now at least the big policy organizations are recognizing the importance of this. And one of the things that you can do when you get back to your situation is ask, are the TB and the HIV services integrated? And if they're not, why not? There is no reason why TB/HIV services should not be integrated. And you'll find, and this might win you your Pulitzer Prize, that it's criminal that they're not integrated, but someone's got to say so, because they have so many vested interests keeping them separately. It's really almost comical if it wasn't tragedy. And then we have multiple drug-resistant tuberculosis and XDR-TB, huge problem. As we said, 630 new MDR cases estimated annually, with a quarter of them dying. Those are not good odds. XDR-TB, I had on this slide 84 countries. I was at a conference here a couple of days ago, and Mario Viglione, who you will meet or have met, who's the head of the Global Tuberculosis Program at WHO, said 92 countries. So, again, I couldn't change the slide because these guys already had it, and I didn't want to. I'm very lazy. But it's 92 countries. And 19% of estimated multiple drug-resistant tuberculosis detected. So here are all these MDR cases, and only 19% are being detected, and you can't treat them unless you detect them. So that needs a lot of work in detecting MDR cases. And treatment. You know that before TB drugs were invented, okay, TB drugs were only invented in most of our lifetimes. In the late 1940s, they started inventing TB drugs. Before then, there were no drugs for the treatment of tuberculosis. And the 5-year survival rate for tuberculosis before TB drugs was invented, everybody didn't die. Half of them died. The 5-year survival rate was 50%. And now if you look at the survival rate for people being treated with multiple drug-resistant tuberculosis, 48% are successfully treated. So we're not doing any better than when we didn't have any drugs before. So our treatment for MDR-TB is really terrible. So we need new drugs. We need to make sure that people are treated properly. And a lot of that needs to be done. And it's not being done as quickly and scaled up as quickly as we want. And about 85% of the global burden of multiple drug-resistant tuberculosis is found in 27 countries. Now, how does multiple drug-resistant tuberculosis occur? It's man-made. It doesn't exist in nature. You know, you're not going to go and catch MDR-TB. You're going to catch it from somebody who was infected with someone who had MDR-TB, who was treated improperly and took his medicines improperly. All of this is man-made. And if people treated TB patients properly and everybody took their medicine properly with good directly observed therapy, there wouldn't be any MDR-TB. And why this happens is because if you take one drug knowingly or unknowingly with a large bacterial population, the sensitive bacilli are killed by that one drug, but the resistant bacilli multiply unimpeded, and the resistant bacilli become dominant. Here's a schema. Here on your left, you have a TB cavity. And in the TB cavity, you have organisms, these are TB organisms, that are sensitive to all antibiotics. And they don't have a letter in them. They have little pictures of organisms in them. And then you have the yellow-green organisms with I, and then they're resistant to isoniazid. And then you have the white organisms with R, they're resistant to rifampin. And then you have the Z, pink, and they're resistant to pyrazinamide. And the E, blue, and they're resistant to ethambutol. Those are all important TB drugs. So if you treat that cavity with isoniazid, rifampin, pyrazinamide, and ethambutol, and you go to the top circle, what happens? All the organisms are killed, or the cavity is sterilized, the patient is cured. And that is because any of these antibiotics can treat any of the organisms that are sensitive, but the resistant to isoniazid organisms can't be treated by rifampin, but by isoniazid, so they're treated by rifampin, pyrazinamide, and ethambutol. And the resistant to ethambutol organisms can't be treated to ethambutol, but they're treated with isoniazid, rifampin, and pyrazinamide. So you can see we use multiple drugs so that at least there's one antibiotic that can treat the organisms that are resistant to the other antibiotics. Very, very simple. That's why we treat TB with multiple drugs. But look at the bottom panel. Here you have, remember, the yellowish organisms are resistant to isoniazid. And here some misguided physician sees a patient with a cavity, says, oh good, isoniazid works against TB, I'll treat with isoniazid. So what happens? The isoniazid kills the sensitive organisms, it kills the organisms that are resistant to rifampin, it kills the organisms resistant to pyrazinamide, it kills the organisms resistant to ethambutol, but what does it do to the organisms that are resistant to isoniazid? Not a damn thing, because they're resistant to isoniazid, and if they're resistant to isoniazid, the isoniazid won't do anything with them. So the doctor says, I'm going to treat with isoniazid, and after a length of time, what happens? There's no other organisms in the cavity except organisms that are resistant to isoniazid. So this doctor, well-meaning or not, maybe he was a crook, who knows? But he created a patient with isoniazid-resistant TB. Now, isoniazid-resistant TB isn't multi-drug resistant tuberculosis. It's single resistant to isoniazid. Okay? And then the isoniazid-resistant organisms over time start to mutate because there's a specific mutation rate. And if you have a lot of organisms, you have mutation, and 1 out of 100,000 or 1 out of 1,000,000, and that's how many organisms are in the TB cavity, 1,000,000 organisms, or 10 million organisms, mutates, and by chance you get resistant to another antibiotic. So you can see the isoniazid-resistant organisms mutate, and you get some that are IP, resistant to isoniazid plus pyrazinamide, others are IR, the white ones there, resistant to isoniazid, and rifampin. That's multiple drug resistant tuberculosis by definition. And then the doctor says, oh my God, I'm only treating with isoniazid, the patient's still sick, maybe I'll add rifampin. So he adds rifampin. First, second, third, fourth, and fifth rule of the treatment of tuberculosis is never add one drug to a failing regimen. And he added one drug to a failing regimen. He added rifampin. And what happened? The isoniazid plus rifampin killed all the organisms in the cavity except the ones that are resistant to isoniazid rifampin. So now you have a cavity filled up with isoniazid and rifampin resistant organisms. So this doctor manufactured a case of isoniazid rifampin or multiple drug resistant tuberculosis. And then these number of organisms, they start to mutate to get additional resistance, and you can see one already there resistant to isoniazid rifampin plus pyrazinamide, on and on and on. So the lesson here is that multiple drug resistant tuberculosis and ultimately extensively drug resistant tuberculosis are man-made, do not occur in nature, and they're made by a patient doing this inadvertently or a doctor doing this, and that's bad. We got to train him and not allow him to do that. So you say, why 4 drugs? Well, we used 4 drugs so that the large population of highly active growing bacilli is taken care of by all the antibiotics. Because remember I said there's mutations that confer drug resistance, and those are known numbers. 1 out of every 1,000,000 organisms, 1 out of every 10 to the 6 organisms becomes resistant with every cell division to isoniazid. With streptomycin, 1 out of 1,000,000. With rifampin, it's 1 out of 100 million. With ethambutol, it's 1 out of 100,000. So when you have a large bacterial population, you have to use multiple drugs. So as we said, the isoniazid can kill the other resistances, rifampin can kill the other resistances, because the likelihood of an organism spontaneously resistant to 2 antibiotics is a product of the probabilities. So you add the exponents, and those are very, very tiny numbers. And if you do them properly, you don't get drug resistant. If you treat people with the drugs they're sensitive to, make sure they take the medicines properly, they don't get drug resistant. And if they don't get drug resistant, you've prevented drug resistance, you cured the patient, and it's much easier to treat regular TB, drug-sensitive TB, than drug-resistant TB. It's cheaper, less toxicity, and shorter courses. How many MDR cases are there? Again, World Health Organization data for 209. India and China have the most, approximately 100,000 each, and then former Soviet Union has the next most. Again, those are where there were not good tuberculosis programs, and transmission, that's why there's so much drug-resistant TB. Countries that had reported at least 1 XDR case by 2010, I can't keep up with this map. As I said, it's now 92 countries, so I don't even remember how many countries are written down here, but if your country doesn't have it today, it will have it tomorrow, because that's just the nature of the game. Now, everybody in the TB community, and here too at this meeting, they talk about resistant TB, resistant TB, resistant TB. MDR, 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 XDR, XDR, XDR. But the key thing, and this is a letter I wrote to the Lancet, which is a important medical journal, published in 2009, which I'm going to read to you because this is an important principle, is the concern, and I called it unsexy tuberculosis. The concern and attention to XDR-TB is appropriate, but skips the more important message. And the more important message is that XDR-TB and MDR-TB and drug-sensitive TB are all the same disease, caused by the same organism. The only difference is that MDR-TB is drug-sensitive TB modified by inappropriate treatment or drug taking, and XDR-TB is MDR-TB, thus modified. And we need to recognize that there's 8.7 new active, then when I wrote the letter, new active drug-sensitive cases of tuberculosis globally that are feeding drug resistance. And it might be less sexy, but all of those cases, the drug-sensitive regular cases, have to be appropriately treated with current strategies. That is, new diagnostics, new drugs, vaccines, and proper infection control, which not a whole lot of people mentions, to avoid preventable MDR-TB, preventable XDR-TB, stress the word preventable, which are always lurking. In preventing active drug-sensitive TB, or treating it properly, should be everybody's priority. It's the only way to prevent MDR and XDR-TB. Everybody forgets that regular sensitive drug-sensitive TB is easy to treat, takes 6 months with 4 antibiotics, bingo, patient cured, doesn't infect anybody, doesn't have MDR-TB, doesn't get toxicity. Much easier than waiting and treating MDR-TB where the cure rate is 70%, or XDR-TB where the cure rate is 50% or less. Now, where's TB transmitted? Here's some pictures we took in Tomsk, Siberia, in the prison there. And here's 30 prisoners in a room, a cell. And you know, it gets cold in Tomsk in the winter, so the windows are closed. And here these 30 guys in this tiny cell, all sweating away and coughing. They may have bronchitis, but they may have TB also. And this is the women's pavilion. But here you can see there's 30 guys in 10 beds. They sleep in shifts. All of their belongings are in these plastic bags hanging at the foot of the bed. One guy gets TB at the end of the cell, the sentence in the cell, they're all going to have TB. And if it's resistant TB, of course the resistant TB is going to be spread. Now let's switch and look at how we get MDR-TB and how we have persistence of TB. And that's inadequacies of physician practices. The major physician practice in developing countries, in developed countries, in my countries, the United States, the delay in making the diagnosis, in thinking of TB, delays in diagnosis and errors in treatment. You know, in the U.S. we have something like 600,000 physicians, and we have less than 10,000 cases of tuberculosis, so you do the math. Each physician, even if you take out the psychiatrist, each physician is going to see one case of tuberculosis in a lifetime, so he's not going to think of tuberculosis. And that's a problem, because the delays in diagnosis and errors in treatment results in increasing risk and likelihood of disease transmission, more advanced and complicated diseases, lengthened hospital stays. Regular TB patient hospital isn't even required, only when they're very sick and have complications do they need hospital stays. Increased medical costs, development of MDR, and totally drug-resistant TB. World TB Day 2006, Dr. J.W. Lee, who was then the Director General of the World Health Organization, launched the international standards for TB care and the patient's charter for TB care. And the international standards for TB care set up standards which all physicians should follow for TB. There's no way internationally you can hold them accountable, but say, hey, these are the standards, and if they're not following those standards, then you guys, the journalists, can ask, why aren't those standards being followed in our country? The key partners in implementation of these standards were national and local TB control programs, ministries of health, influential professional societies, professional nursing and medical schools, non-governmental organizations, patient and community organizations, technical agencies, and funding agencies. And the international standards were very, very simple. They just said anybody with an unexplained cough lasting for 2 to 3 weeks or more should be evaluated for tuberculosis. And microbiological evaluation, smear, which is low tech, is essential for all patients, including children, extrapulmonary, as outside of the lungs, and people with radiographic abnormalities. The provider, the doctor, is responsible for prescribing an adequate regimen and ensuring adherence. I mean, it's no longer do you say, oh, take your medicine, bye. Take your medicine, are you taking any medicine? Can we set up a program to see that you take the medicine? Maybe we'll talk to the health ministry to make sure you take your medicine and things like that. The doctor just can't say, here's your medicine to take. The doctor is responsible for ensuring adherence. 50% of people don't take the medicine as prescribed without assistance. 50%. Those are shocking numbers. Yeah, black, white, rich, poor, doctor, nurse, alcoholic, addict. It's not related to any of those things. 50% of people, and 50% of journalists, don't take the medicine as prescribed. 50%. A patient-centered, individualized approach to treatment should be developed for all patients. And a central element is direct observation by a treatment supporter. We talked about directly observed therapy, that one element there. And that is, we don't trust you to take your medicine, no matter who you are. And that one of our people has to watch you take your medicine. If you're being treated for high blood pressure and you don't take your medicine, you have a stroke, that's your tragedy. If you have diabetes and don't take your medicine and have diabetic ketoacidosis, that's your tragedy. If you have TB and don't take your medicine, you spread TB to other people, you spread resistant TB to your children. That's our tragedy. So we have to make sure you take your TB medicine. So where are the missing cases? Well, they're not detected during the poor laboratory capacity. In an era of high tech, this is the laboratory in India, which is sort of bare bones, and they don't do a very good job detecting cases there. Or they're home if the services aren't accessible. If that patient in Nepal who has to trek 12 hours for treatment, or in some of these areas in Peru or Africa where they have to trek long periods or the physician can't come to them or they're too sick to travel, the cases are inaccessible. Or here's some of our prison photos in Top Siberia, in unconnected public systems like prisons where a lot of TB transmission occurs. Or in the private sector, here's the street in Mumbai, India, and here's all the at least four physicians' offices side by side. And they give the bulk of the care in India, and with 50 or 100 patients a day, I assure you they're not taking a careful history and looking for TB and doing proper diagnostic tests for TB. And then there's the patient involvement in medical care. Patients and their families have become increasingly involved and influential in all aspects of medical care. In the mid-'80s, beginning of the AIDS epidemic, as antiviral drugs for treating AIDS were being developed, activists demanded to participate in the clinical design of clinical trials directed by the National Institutes of Health and the pharmaceutical companies. Now lay people sit on the committees of the NIH and hospitals' institutional review boards, which assess the ethicality and scientific merit of clinical trials. And this led to the Patient's Charter for Tuberculosis Care. And the Patient's Charter says, let's empower the patient. It's a companion document to the international standards. It's initiated and developed by patients from around the world. It's a patient document. It outlines the rights and responsibilities of people with tuberculosis. We said rights and responsibilities, not only rights, but responsibilities. And it affirms, excuse me, that empowerment is a catalyst for effective collaboration of the patient with health providers and authorities. Patients' rights. Hey, you patient, you have the right to care, dignity, information, choice, confidence, justice, organization, security. But you have the responsibility to share information, to follow treatment, to contribute to community health, and to show solidarity. So, and this document is rarely used. I mean, hey, doctors don't show it to patients and say, hey, let's work together. You have all these rights. We're going to make sure you follow all these rights. But you also have these responsibilities. Now, in the United States, TB graph looks like this. You can see there's a tail going up there to your left, and that goes straight up in that pitch. Since 1953, they started counting cases in the U.S. only in 1953, and the cases fell down and down and down, and they fell down 5 or 6% a year since 1956. And then they leveled off, and that's what comes onto this slide. And where the double arrow is, they started to rise. And they rose in early 1990s, late 1980s to early 1990s. They rose 20% in adults and 35% in children. This is the largest rise of TB in any industrialized nature ever, and it was in the United States. And why did that happen? It happened because of the impact of the HIV epidemic, which was just starting around then, poverty, homelessness, and the failure of the public health infrastructure. And when I say failure of the public health infrastructure, some of the wise people who run the government in the United States said, oh, we don't need to put money directly into TB control. We'll give the money to the politicians and let them allocate it. So, of course, they didn't allocate it to TB because TB patients aren't very articulate and don't know how to ask and don't know how to advocate. So the rates went up, and that's what happens if you take away the money. The rates go up, and that happens in your country, and that happens in my country. And if you don't believe it, watch it and see what happens when they always take the money away, and the rates go up, and then they put the money back. And now look at the rest of the graph. Here we are now in 2013. Last year we had historically low, less than 10,000 cases, a rate of 3.2 per 100,000. And if you can compare that to the maps that I showed earlier, with a rate of 100, 200 per 100,000 in some developing countries, it shows what you can do with decent tuberculosis programs. But they also recognized that when the graph went up back there, where the arrow is, it was not something that was commonly seen or used, and there was a lot of publicity. And this is a newspaper in New York City, the New York Post, front page, TB, highly contagious TB, close to epidemic levels in the city. That moves politicians, that gets funding. That's your responsibility when you see a TB problem, and this is a preventable, curable disease that is still afflicting 8.7 million people a year, and lots in your country. And also got a lot of international publicity. Same time, this was the front cover of Newsweek. In those days, Newsweek was it's recently demised, but in those days it was a potent magazine. Front cover, that moves a lot of politicians, gets a lot of attention. So the United States response to the MDR epidemic, because where that arrow was, there was lots of multiple drug-resistant TB, was strong public health advocacy to obtain increased funding from Congress, rebuild the infrastructure for TB services and research, implement routine drug susceptibility testing with liquid media, implement and monitoring infection control precautions in healthcare and congregate settings, strengthen public-private partnerships, support centers of excellence to demonstrate good care of TB patients, and a 5 to 10 year National Institutes of Health investment in TB academic awardees who were actually academicians who were trained to teach about TB and making it the specialty of TB an important specialty. And now in the U.S., 2012, only 9,900 TB cases, 3.2 cases per 100,000 population, historic lows, a decline of 6.1% from the 2011 case rates. So advocacy works, and advocacy turns into program support, and program support brings down TB rates. So we're at a crossroads of global TB control. We have the U.S. decline of TB now since prior to the development of drugs. TB's been going down. But there was a U.S. resurgence of TB during the 80s and 90s, largely due to neglect. We had a massive and effective response. We had TB on the radar screen domestically and TB on the radar screen internationally. But TB remains a global killer, and the question still needs to be asked, why does TB still infect a third of the world's population and remain a global health threat despite the fact that highly cost-effective drugs are available to eradicate it? And it's really because of these challenges. We have insufficient financial and human resources, we have inadequate healthcare infrastructure, we have weak laboratory capacity and lack of new rapid diagnostic tools. We have lack of new drugs that would cure TB in a shorter time. We have lack of an effective vaccine that would prevent TB. We have poor use of infection control in healthcare settings. We have HIV and MDR and XDR threats. And we have minimal social mobilization for TB control, minimum population awareness, and that leads, of course, to stigma. Why do we need new drugs to treat TB? Because treating a regular TB case 6 months, treating MDR-TB case 24 months. Any of you ever take medicines for 6 months or 24 months? We need to have lower relapse rates. We need to develop regimens with fewer adverse effects and less hepatotoxicity. We need regimens that can be given easily and safely in combination with antiretroviral drugs. Since so many of our TB patients also have AIDS and they get antiretroviral drugs, and the antiretroviral drugs interfere with the TB drugs and make all sorts of toxicities, that's scary, so that makes it hard to treat. And we need to develop regimens that are effective in treating MDR and XDR-TB. And people who already have MDR-TB, a study was done last year, published by Tracy Dalton from the CDC, that showed in 8 countries, a prospective study. That means they start studying as things go on and they note the results rather than do it after it's finished. They found in almost 1,300 patients, 47% had resistance to 43%. One second-line drug. Second-line drugs is like the final protection. Okay, 20% resistance to one second-line injectable. 13% resistance to one fluoroquinolone. And almost 7% already had extensively drug-resistant tuberculosis. And what was the constant risk factor? Previous treatment with second-line drugs. So even though these people are being treated, they're also generating drug-resistant, multi-drug-resistant tuberculosis, which is also scary. Now, this is just to remind us that once upon a time there weren't drugs to treat tuberculosis. This is the treatment of tuberculosis in New York City around 1900. And this patient was getting the fresh air treatment living on the roof of her house. Okay, and that's what they did in those days. Okay, and that's because they didn't have any drugs to treat tuberculosis. What do you look at? Drugs in the clinical pipeline for the world's leading causes of mortality. So in your left-hand column, leading causes of global mortality. Heart disease, stroke, chronic lung disease, you can go right down the list. And then color-coded in the right hand are the number of drugs in clinical development. So heart disease, 299, chronic lung disease, 54, antibacterials and antivirals, 69, cancer, 900. And look at anti-tuberculosis there. It's still the 10th leading cause of global mortality. Only 5 to 8 drugs are in the clinical pipeline for tuberculosis. We have new diagnostics. I'm sure you'll hear a lot about Gene Expert at this meeting. It's a molecular method of diagnosing multi-drug resistant tuberculosis in 2 hours. And WHO wants to put one in every street, and they've already probably mobilized about 2,000 machines and 5 million. It works like an espresso machine, if you've ever seen it. You put a little module in there. And 5 million of those Nespresso modules have been demonstrated. And what's happening is the rollout is so successful that they're making so many diagnoses of MDR-TB cases that they can't treat them all in various places. So as we cure increasing numbers, the remaining cases are the most difficult to treat, with impossible social problems, severe, virtually untreatable, still transmissible. Drug-resistant tuberculosis, drug-resistant TB is transmissible. And just because it's harder to treat doesn't mean it's less transmissible. So with DOTS and case management, along with funding, interest, involvement in developing new tools and strategies for combating TB, we've taken care of the easy cases. And then when we take care of the easy cases, expertise decreases, funding decreases, and innovative initiatives are de-emphasized and forgotten. So there's several key challenges persisting. Many vulnerable cases don't have access to affordable services. Technologies for diagnosis, treatment, and prevention are old and inadequate. Multi-drug resistant tuberculosis is a serious threat in many settings. HIV/AIDS continues to fuel the TB epidemic, especially in Africa. And other risk factors and underlying social determinants help to maintain tuberculosis. Here's a true story. We had a patient with tuberculosis who was, and we have a very good tuberculosis control program. We have 99% cure rate, and all of our patients are on directly observed therapy. One of our towns, Fort Lee, New Jersey, in northern New Jersey, right across the George Washington Bridge, if you know the Manhattan on one side, Fort Lee on the other side, we don't give direct the treatment ourselves. The health department in Fort Lee gives the treatment. And the health department, we had a patient, he was a Turkish gentleman, and he had multiple drug-resistant tuberculosis. And so we said, okay, we're going to put him on this complex regimen for multiple drug-resistant tuberculosis. And the health department says, well, we can't be responsible for all those drugs. Give him all the medicine, and we'll send our nurse in every day to watch him take the medicine. DOT, standard of care in U.S. and New Jersey. So patient stops coughing, feels better, wants to go back to Turkey. They finally get him a plane to go back to Turkey. MDR-TB. And you're not supposed to fly on an airplane if you have MDR-TB. And after he leaves, the landlord cleans out his apartment because he wants to rent the apartment to somebody else. And this is what he found. That's all the medicine that was prescribed for this patient was still in the apartment, untouched. And this is a patient on directly observed therapy, where the Healthcare worker watches the patient take the medicine. What happened? Well, you can imagine what happened. He said, oh, I don't feel well now. I promise I'll take the medicine later. And what's the directive therapy? Oh, you gotta take it. I don't trust you. I don't believe you. No. So directly observed therapy doesn't work unless all the people involved make it work. Anik Rion was the executive director of the union 2 executive directors ago. You met Jose Castro, and last year, the executive director for the last 20 years was Nils Billow. And Anik was before him. And Anik wrote in an editorial in the Bulletin of the International Union Against Tuberculosis in 1972. That's even before the International Journal. And an editorial called Defaulters and Motivation. And you should remember this because this is really behind everything we do. To default is the natural reaction of normal, sensible people. The person who continues to swallow drugs or have injections with complete regularity in the absence of encouragement and help from others is the abnormal one. So why do we need to care for TB in the rest of the world? Well, this is something I saw when I was flying over here last week. The Transportation Security Administrator, going through the metal detector, and he says, "Have a nice flight, sir." And the guy had to take off all his clothes and everything. And he says, he missed the TB. I don't know if you all remember, this is the last slide, I don't know if you all remember Andrew Speaker. Andrew Speaker was a white middle-class attorney who about 6 years ago had extensively drug-resistant tuberculosis, and he insisted on going to his wedding in, I think, in Czechoslovakia. He was in Atlanta, Georgia. And he said, oh, you can't fly. He was on a do-not-fly list. He had multiple drug-resistant tuberculosis. And, but he got on a plane, and he flew, and he was in the front page of every newspaper for a week. It was a one-week story. He's this guy with TB, and he eluded all of these safety nets and everything like that. But there were a lot of lessons from the Andrew Speaker story. And of course, he was a white middle-class attorney, very articulate. So, people who have ethnic profiling for TB cases were shocked. So this got a lot of important lessons for TB. TB is not going away. It remains with us, highly prevalent and transmissible. Anybody can get tuberculosis, not only poor people, minorities, foreign-born. TB anywhere is TB everywhere. All resistant TB, multiple drug-resistant tuberculosis, extensively drug-resistant tuberculosis, is preventable by proper TB diagnosis and treatment. Good public health, it's a silent secret, but when there's a small glitch, it becomes major news. We desperately need new tools for diagnosis and treatment, and you don't want to sit next to someone on an airplane for 8 hours next to an untreated coughing person with any kind of TB being in drug-sensitive MDR or XDR. The reason I have it in there is because he had XDR-TB, and then his laboratory work was repeated by the lab in National Jewish Hospital, and National Jewish Hospital said, no, it's only MDR-TB. So immediately it became a non-story. XDR-TB has a 70% fatality rate, MDR-TB has a 50% fatality rate, so it becomes a non-story because it's not 70% anymore. Or you can put your head in the sand and just continue doing what you're doing and not worrying about TB. Thank you very much. I'd like to answer any questions.
I have a question. If you have TB of any type, you go on treatment, at what point is your TB not transmissible?
Well, first of all, you said of any type. Only pulmonary TB is transmissible. You have TB in the big toe or the lung or the testicle or the ear or the bone is not transmissible. Only pulmonary TB is transmissible. TB can affect any organ. 15% affects organisms outside the lungs. With AIDS, it's more like 50% because in AIDS, the immune system's working and the immune system determines where your TB goes. So only pulmonary TB is transmissible. Extrapulmonary TB is never TB. Meningitis sounds scary, kills you, but it's not transmissible. But answer to your question is if you start someone on TB medicine and follow their sputum smear, not their culture, you'll see a rapid decline in the number of organisms in the smear. The act of transmitting tuberculosis is dependent on the number of organisms you cough up, the height of the ceiling, the amount of ventilation, and those kind of things. Like if I have fulminating tuberculosis and I'm coughing here every other sentence, I'm not going to spread it to any of you people because it's a big room, there's ventilation, the ceiling is like 18 feet or something like that. And TB mostly is spread in a small place. I'll spread it more likely to my significant other tonight when I'm in the house with them than spending an hour talking to you guys. There's also time is involved. And this has been studied, and it's been found it takes about 6 months of 8-hour-a-day contact with an untreated case to have a 50% chance of getting infected, untreated case. So much, or 2 months of 24-hour-a-day contact. Who do you hang out with? You spend time with your wife and your kids. So you're more likely to infect them. So I always get asked, can you catch TB on the metro? The answer is not no. Because there's no definites here. The answer is yes, but it's more likely the metro will crash. Okay?
Especially in Washington.
Yeah.
Or in Paris. Or in Paris. I was on a metro this morning. There was no one driving it, so I didn't know myself.
What questions do you all have? We just have a couple minutes, so we'll zip through them.
Say again?
When we have a suspected TB case,
Yeah.
do we need to, test him on both the TB virus and MDR-TB virus?
Well, what they do is they test for TB, okay? And then after they get the test for TB, they test to see if it's MDR, if it's using regular bacteriologic. If you're doing expert, the expert will tell you if it's MDR right away, within 2 hours. So it depends. Usually the identification of an organism before expert would take 2 months. Okay? So doctors deal on suspicion. I suspect you have tuberculosis. I'm going to isolate you. I might start treating you. And then when the cultures come back in 2 months, oh my God, you don't have TB. Expert tells you right away. The expert also might tell you you're MDR. And then you need the capacity to treat the MDR. And a lot of countries don't even have that capacity.
Actually, just wanted to ask you a question related to the TBR, because you were also mentioning the TBR, right? Though in the dictionary of WHO there is no the technical word like XDR or the TBR. There was a case which you are also knowing that last year there was 8 or 11 cases of the TBR in Mumbai. Though technically most of the officials are saying that it's not a TBR, just because they, in that particular direction.
Do you have a question?
So why WHO is not exactly including TBR?
WHO had a consultation about that very issue, and WHO has very, very stringent criteria about whether they accept the diagnosis based on the laboratory, based on the reporting, based on the culture. I don't know all the ins and outs of it, but they didn't think there was enough evidence to say that there was a case of TBR yet. Now, whether there was or whether there wasn't, the potential is there. We know how it comes. Doesn't matter if there was a case of TBR or not. XDR is bad enough. TBR maybe is 100% fatal. XDR is 70%. That's not good odds either. We got to do something about it and make sure we don't get TBR cases by treating regular TB to prevent MDR, XDR, and possibly TB.
Bo, did you have a question?
Yeah, I understand. What do you think is the most effective way to get more people, more patients into
Just people, patients have to present themselves when they have symptoms. People weight loss, cough. doctors have to think of tuberculosis first rather than last. In my country, it takes 2 months sometimes to make a diagnosis of TB. And we've had tragic situations where they said, oh, you know, this is a white middle class person, they don't have TB, and by the time they say, oh my God, maybe that's TB, the patient is sicker, he's already infected the kids, one of the kids has meningitis, one of the kids died, because the doctor didn't think of TB. In this case, might have TB. We don't see a lot of cases of TB, but TB occurs in black people and white people, in Asian people and middle class people, and the thinking doesn't go that way. And that's what you guys, as journalists, can do, to keep bringing that up. And if somebody misses a diagnosis, embarrass the hell out of them. And he'll never miss, and he won't miss a diagnosis again. And, you know, if some famous doctor, and wherever you are, misses a diagnosis of TB and you find out about it, you embarrass the hell out of him, not because he's friends with your publisher. You want to embarrass the hell out of him, then he said, oh my God, I'll never do it again, or I might have to retire or move somewhere else. But none of the other doctors want to have you breathing down their neck. That's the way to do it. Activist reporters.
Doctor, my question is about the spread of TB. So, if someone has multi-drug resistant TB or extremely drug resistant or extensively drug resistant TB, you know, these 3 forms of TB, how will they get transmitted to the opposite person?
Same way.
The same way?
They used to say, and some people still think, that when the organism becomes resistant, by becoming resistant, it loses some fitness. The organism loses some fitness, and therefore doesn't transmit as efficiently. That's probably not true. Any organism can transmit. It takes prolonged contact, and if you have XDR-TB and you and I hang out a lot, I'm going to catch your XDR-TB. I'm not going to catch your sensitive TB because I'm not hanging out with someone with sensitive TB. Any TB is infectious.
Are there research papers on this transmission methodology?
Oh, sure. There's tons of transmission. What I showed you there is probably the most simple kind of thing. Richard Riley was the person who demonstrated by patients, treated patients, don't transmit TB. You know, in answer to the question before, if you treat someone, it probably takes a couple of weeks, they won't transmit anymore. They still have TB, they still have to be treated for 6 months, but the transmission falls off after a couple of weeks.
Thank you so much.
Thank you.
Awesome.